Now everybody is saying they've changed the forecast again. Hello, Tim.
I'm here. Hi, guys. I'm just taking attendance as the names pop up.
Hello there.
Hey, Doc.
How are you, Timmy?
Good, thanks. You got your Narcan okay?
I did. Thank you very much.
You're welcome. When I get more, I'll let you know.
Great. That'll be perfect. I have enough to get the police started, and it's just I got to have more for backfill.
Okay.
Hello, everyone. It's Alicia Parker joining the call.
Hi, Alicia.
Hi.
Tim, am I supposed to be seeing anything or just a meeting topic?
You're not really supposed to see anything. I'll show you my face.
Oh, actually, I see a silhouette of you.
Okay. But nothing else. No, you're okay.
All right.
Hi, Tim. This is Bill Rockenstar. It's got me signed in as car 29.
Welcome, Bill. I was wondering who that was.
Yeah, I'm using a work iPad, and it's not letting me log in as myself, so I'm just going to roll with that.
Yeah, that works.
That's okay.
Ron, would you mind taking the point to kind of help us regroup here in the next couple of days?
Yes, absolutely. I know we're running out of time. Kim mentioned something. She was getting ready to mention something at the beginning.
Hey, Tim, Steve Hassett as well.
Hi. Welcome, Doc. Dr. DeMays, welcome to you also.
Welcome. Count Sam Bosco in. He's going to be in my office with me, so he's not signing in, okay?
10-4, I just checked them off.
Okay, thank you.
Anne Marie Cross will be meeting.
Okie dokie.
Hi, this is Jay Lawrence from the Grand Healthcare System.
Welcome, Jay. This is Tim from Remo. We haven't kicked off yet.
Terrific. Thank you.
Hi, this is Nona from the Grand.
Welcome, Nona. Well, welcome, everybody. This is Tim from Remo here. It's now 3 p.m., at least according to my clock. So I'll turn the reins over to Dr. Rob McHugh, the chair of the Remac, and Doc, you can kick things off.
Okay, welcome everybody to October. Can I get a motion to approve the minutes for the last meeting we had back in September?
Make a motion. Okay. Second.
Second.
So I'll do some quick housekeeping, and then I think we'll do the Grand issue first since they're on, so I don't have to sit through the rest of our meeting. And then we'll do the committee reports after we get done the Grand discussion. Does anybody have a problem with that? Okay, so I'll just do the correspondence. Nick Walker, Plattsburgh, New York, EMT 422046. Certification suspended for 1 year, effective 9/23. Pending completion of full ACLS and PALS within 6 months. And he's on 3 years probation, effective 9/20/20, and assessed civil penalty of $5,000 for violations of Part 800.15A2 and 800.3. Okay. I did want to make one quick note for those of you in the region. It's announced today that Ellis is going to be affiliating with / merging with St. Peter's Health Partners. So I will be joining Sam and Frank and all of them speaking for them. So I just want to put that there. It'll be a long time till we know if there's any change in the actual capabilities of Ellis for you guys to worry about where you're taken. So just wait for the next 6 months to 2 years to get any clarification on that. Okay. So Mike, do you want to lead the introduction into discussing the nursing home transfer form with the Grand?
Yeah, absolutely. Jay and his team came on in and chatted with me a little bit about the process of making sure that appropriate patients were being brought to the hospital and how we could then improve handovers between the skilled nursing facilities and EMS, and then ultimately into the emergency department and hopefully back to the skilled nursing facilities if that was most appropriate. I mentioned that we used to actually have a regional nursing home transfer form so that we had a consistent amount of information. As I would expect, Paul Martin from Mohawk Ambulance just came up with that form for us. There it is up on Rob's screen now. I'm not even sure that the font that is written across the top of that form is accessible in any modern version of word processing. But this is what the form used to look like. So I think what probably would be the best would be just to let Jay and his team take over for a little while and share with us some of their thoughts. The Grand is now, please correct me, I think it's Guilderland Center and Barnwell is what we used to know them as. It sounds like quite a change. So Jay or Nora, Alicia, somebody want to jump in?
Yeah. Start. And Dr. Daly, thank you for having us here. Tim, thanks also for the invite. Everybody, thanks us. Thank you for the invite. I am in transit here, so I don't have any screens in front of me. I apologize for that, but I do have colleagues on the phone, nurses on the phone. Our regional VP is on the phone as well. And correct, when we met with Dr. Daly about a month and change ago, it was a very prudent conversation about the transfers back and forth, frankly, in the greater interest. And we do hope with you to be able to help develop a plan and process that certainly transcends the Grand and can be utilized en masse. We know that we have had a great deal of experience throughout our portfolio in our 17 facilities in different regions, and have learned a bit as well as to what makes sense and what doesn't make sense. At the end of the day, I think collectively we're all trying to have a better seamless communication, reduce rehospitalization, unnecessary rehospitalization, and achieve better outcomes together. Every hospital system and every team, EMS as well, have their own systems in play. I think unifying for something that makes good sense across the board is prudent. With that, and again, I did see the last email, Dr. Daly, that you had forwarded with the transfer form. Again, I can't really look through that right at this moment, but I know my colleagues can. And I know, Nona, you're on the call here. Why don't you take lead on it from here, and or if Elizabeth or Alicia or Jake, who's on the phone, if somebody has input on that actual form, that would be very helpful at this juncture. Nona, are you there?
I just got the form, so I haven't had time to review it. So just a minute, please. It's Alicia.
Oh, Alicia, thank you. But I think, go ahead,
sorry,
please.
Jay, what I was going to say is the important thing I think for us is not what the form used to be, but what the form could be, and
Absolutely.
making sure that the most salient information about the patient's care, the patient's baseline, the expectation of the trip to the hospital, and most importantly, as we discussed, who we should be contacting from the hospital in order to get the patient taken back to assure that indeed the care that we are providing is in line with the care goals of the facility and the facility medical staff is probably the most important things that need to be on here, as well, obviously, as the patient's primary, as the patient's family contact.
Yes, and to that point, I agree. I think we all agree that it's less about the form and more about the process. With respect to the facilities, and it is the Granite Guilderland and the Granite Barnwell that are the closest facilities to you. I think that particularly during off-shift times, there is a breakdown traditionally in terms of communication. And to your point, who is the key contact? Supplying phone numbers is not enough, but to be able to achieve it in the best case scenario, perhaps doc-to-doc communication, to again, while somebody's in observation, perhaps in the ER, make sure that they are treated properly, or we find out a proper baseline for that particular patient before they're admitted into a hospital, to make from a standpoint that you folks have what you need from our side of the coin that can help that as smooth as possible. And again, I know that the nurses on the call here, as they're looking at the document.
So, hey Jay, it's Alicia. So I'm looking at it. It looks more. It's a shorter version. We currently have in place the e-interact, which is it can be hard to read once it's printed out. So this looks like a more of a compact, basically form that you get the most information that you need, especially when coming to the ED, without having to look through the whole e-interact. So typically our facilities at the Grand, when a resident is transferred out, the e-interact transfer form is supposed to go along with the resident for the ED. And it's supposed to have all of the pertinent information that's needed to take care of that resident. Also, it should have who to call at the facility with any questions as well. I know that on our end, we are trying to get our nursing staff to complete the form in its entirety. So, and it may be because there are so many different sections on the e-interact to complete. That's why it's not coming to the hospitals fully completed.
I think the important thing from my perspective, just in an emergency department and any of the other receiving docs, chime in. If the e-interact is ultimately going to be the easiest way for those nurses to complete the information and the easiest way for you to then do continuous quality improvement to assure that it's being done correctly, I would encourage its use. I'd ask if you could send us a blank one or one that's completed as an example, so that we can look at it and then give you feedback on how it potentially could be improved to help us take care of your patients.
Definitely. And so also on our end at the Grand, I know that there are issues with the transfer as far as with handoff report, getting a clear picture of why the facility is sending the resident to the hospital for evaluation. Would it be helpful in addition that whoever our nursing supervisor or the nurse sending the resident out calls the ER to give a handoff report verbally?
I think each one of the hospitals is going to be a little bit different for that. Certainly at Albany Med, we have a transfer center.
Yes.
Calling that transfer center with any information about the patient that's incoming to us is always the best way to make sure the information is accessible to all of the emergency department staff who will care for that patient. Frank or Sam, would that be the best way for a patient to enter into the St. Peter's system as well? Through your access center?
Mike, I'm sorry. I apologize. Sam and I were talking about something else for a second there.
So I would say as part of this process, we should just pull all the hospitals to see what our best notification process would be. And when we put out the form or request, we can put along with that, this hospital, this is where to contact her, or just send by emails, which hospital wants.
I
Great
like
idea, Rob.
Yeah, and to jump in for Sam, it's because they were distracted a little bit, that using the St. Peter's Health Partner Transfer Center probably would not be a good idea just yet. That's undergoing a lot of revision. So right now, St. Peter's would do better by calling each individual ED. However, in time, that may change.
I still don't know what the question is.
And the question was whether the nursing home should call St. Peter's Transfer Center to give them a heads up on the patient coming in. So there was better transfer of information from the nursing home to the hospital versus just doing what they do now, which is send a whole lot of paperwork.
Yeah, I agree with Bruce's advice at this point, unless it was already an arranged direct admission for some reason, which I've never seen happen from the nursing home. I think contacting the ED with the clinical information is the best route.
So on our end, for the grant, that is something that we can put in place, especially for the upstate region, as far as, still completing the e-interact form, but also calling the transfer center, or as for instance, St. Peter's ED, to give a verbal report to that, whoever the charge nurse is, and ER or whomever, so that there is clear communication.
And I think if you send us a blank e-interact, so we look at it to see if there's anything else we might want, to see if you could add to that for the future.
Yes.
Hi, Rob. This is Steve Kroll.
Go, Steve.
I just have one comment about contacting the ER in advance. As a pre-hospital provider, sometimes the staff in the ER is busier than not, and actually having time to take report from a calling nurse may be somewhat dependent on it. So I think it's important to be certain that even if the facility calls the hospital, that the form still has all the right information on it. So a call cannot be a substitute for a fully completed form, is I guess what I want to share.
Yeah, and it won't be. So that's what this is in addition to the e-interact, is that verbal handoff.
Okay, and part of it also would be if the sending physician wants to talk to a doc, that would probably go along with the best way to contact for each hospital.
Yes, whoever the provider is at our facility.
Question, this is Jay Lawrence. With respect to the prospective phone call to the ER, having experienced this in other locations as well, it gets complicated in trying to reach the appropriate party. Sometimes there are messages that are left and they get buried with other messages. Is there a protocol, theoretically anyway, that can be put in place so that, again, that communication is seamless and does dovetail with the actual paperwork and the appropriate party in the ED is reached? And then again, on our side of the coin, if our MD is to be reached, that there can be that bilateral communication. Is there some mechanism that can be put in place with respect to that? Any thoughts, please?
That would have to be done at this point at each facility level. I know for my hospital, there's one number that any doc can call that you will get one of the ER doctors at any points. And then put a note that when they show up, it'll get merged to their record. Each hospital probably has a different system to do that.
Correct. So well, I guess we'll figure that out on a hospital or system by system basis.
Yeah, we only have a couple hospitals, so it shouldn't be too complicated to have each one say which is the best, which is the best doc communication.
I think speaking with one of the providers is fine. That's not an issue at all.
Yeah, I mean, if there's a need to speak with one of the providers when you're calling into the ED, just asking to do that is totally appropriate, especially if it's a complicated case. In many of the EDs around the area, you're going to have more than one attending that's on at any given time. So So just asking to speak with one of the attendings to be able to report on a patient coming in, you'll get to one of us.
Fair enough. Alicia, that works for you, yes?
Yes, and my main concern, because I'm a former emergency department nurse, and so I know a lot of things get lost in translation too, as far as nurse to nurse communication. So when I worked in the ED, I was a charge nurse at one point. You're able to filter in all those calls, know what's coming in. I think that on the nursing side, it definitely should be nurse to nurse communication. I know that when I was a director of nursing, at times I would have my provider, my nurse practitioner, speak with the ED doc to really clarify why she wanted the resident to be seen, so that we were all on the same page.
Very good. Okay.
Okay, so what are next step with this?
So
I
there's
think
actually
from,
one
side-
more interesting thing that came up, which just came across in a chat to me, which is the other thing that should be on that e-interact form, if possible, is whether or not there are any current infectious disease concerns at the facility.
And I think it's already embedded in the e-interact form.
Okay, good. Thanks, Alicia.
You're welcome.
Yeah, hi.
So to answer to what's next, go ahead, please. Sorry.
Yeah, sorry. I just wanted to add one thing. It's not uncommon to get patients from facilities that are clearly marked as do not hospitalize who are then sent to the ED. It would be nice if this form could address why the patients are actually being sent if it's documented that they do not hospitalize, because it becomes very difficult at the time they arrive at the EDs to try to untangle that. So if that could be answered up front, that would be very helpful.
Yes, that's understandable.
Hi, it's Jake from the Grant. Just on that topic, many times what we found happened is that, we'll call up the family and tell them what's going on. And then a lot of times what has happened pretty recently is that the family will say, I know that there's a do not hospitalize. However, could you guys please still send mom? And we're talking about the power of attorney, and they rescind the do not hospitalize really quickly. And then the patient's on the way to the ED because that's what the family wants, with the paperwork that was just rescinded, even though it's a DNH. We are finding that pretty often.
Right, and if that could just be addressed before the patient is sent, that would be great, because a lot of times we sort of spend time trying to backtrack that to try to figure out what happened.
And that could be solved in a verbal handoff communication. In addition to sending the e-interact, that nursing supervisor following up with the ED as to what's the reason for transfer and anything that changed, most recently or right prior to transfer.
Hi, this is Nona from the grant, and I'm looking at the e-interact tool right now, and it does account for isolation precautions or infectious disease, so we're good there.
No, was that just for that individual patient, or was that also if you're having
it's a standard
to the facility?
It's a standard
part of the
form.
template.
Sorry, too many people on top of each other there. I couldn't understand. Just asking whether this was for the facility itself or just for that individual patient.
So it's a standard.
Yeah, sorry.
So it will e-interact. There are places to fill out everything. There is a standard template, and the nurse is supposed to go in and fill in basically every section. There even should be a section where they can make a little note, and then once that nurse prints it out, and it gets sent off with EMS. So on our end, one of the things that we have to make sure is that our staff is filling out the e-interact in its entirety. So we may have to do some audits on our end to make sure that it's getting completed correctly.
Okay, so from our end, we need to get a list of the hospitals and the best way to contact us. If you can get us a copy of that e-interact form to see what's on it. And then are looking at reaching out to the rest of the residential agencies in the area to go along with this.
Fair enough. So yeah, we'll get you all the form. We can also get a list of contacts on our part too, but happy to share whatever we have.
So I think we'll probably come up with a generic form that would at least get what your e-interact form on it has, and we can send that out to other agencies as use this or have something electronic that's comparable.
Yes. Okay.
Any other discussion on this? Thank you for this.
No, I think we're all good. From us again at the Grant, thank you all so much for inviting us in. We'll supply that documentation, and perhaps we can revisit it in time.
Okay.
Thanks, Jay.
Tim, can you make sure we get contact numbers from all of the hospitals?
Say again, Doc?
Can you make sure we get a list of the contact numbers from all the hospitals, which ones they were, the best way to notify the hospitals?
Yep.
Okay.
So I'm sorry, I didn't hear that. We're going to get contact numbers for all the hospitals, correct?
Yeah, so we'll take care of getting that. We'll pull all our hospitals and have the best way to notify us. And then we can send that out. You send us your list and we'll send us our list.
Terrific. We can do that and reconnect if anything is missing. Again, thank you all for including us in this dialogue. Much appreciated. All best.
Thank you.
Thank you.
Thank you. Bye-bye now.
Bye.
So back to the regular schedule. Committee reports. Don and academic.
Just trying to get off mute there. We did have a discussion on what the appropriate defibrillation dosage is between physio control and Zoll. At this point, it looks like we will wait to see what the new AHA guidelines are coming out at the end of this month. There was some thought on some of our part that we should basically be using the highest setting to start out with currently, because at least from my standpoint, I'd rather defibrillate with the maximum joules and convert somebody immediately rather than essentially wait 4 minutes to get to the maximum joules following current standards where we're doing a defib, 2 minutes of CPR, defib, 2 minutes of CPR, defibbing again. Other folks were a little concerned because of the guidelines from the manufacturers don't follow that policy. So more to come on that as the new AHA guidelines come out. There were a number of courses being offered at Cobleskill and Hudson Valley, as well as Remo. And other than that, really not much else.
Okay. Remsco, primarily the meeting was devoted towards new members. So we're adding Alan Bell from Clifton Park, Adam Fink from Twinsburg, Paul Segru from Colony, Dennis Wood for Albany County, Rich Salucci from Troy, and Bill Rockenstein from Schenectady Fire. So there are all at-large members now. And then also the Remco budget was passed, the Remsco operating budget was passed, and some just discussion about the potential reimbursements from the states and funding crunch that may be coming down the road. Don, do we have anything from CMAC or SEMSCO?
Plus the dates for the next meeting will be December 8th, or committee meetings December 9th for CMAC and SEMSCO. And they will be televised as usual.
And Tom or Deb, QI meeting? I guess Deb, Tom was in the academic.
Sorry, trying to unmute. Dr. Daly was there. I would defer to him, or I'll give a report, whichever.
Why don't you go ahead, Deb, and I'll chime in.
I knew you were going to say that. All right, we had a replacement of someone on the CARES committee at Emory. That information was disseminated to those people who asked. We are moving forward on looking at dispatch issued CPR instruction, and we have a plan going forward with a report expected at the December meeting. Our big issue is provider impressions, which has been on the agenda for more than a year and a half. Paul Segru has made headway in working on that. We're now waiting for EMS charts to fix things on their end. Let's see. Communications from various committees were limited. Either they didn't meet or there was little for the to come to the QI meeting. There was a report from the RTAC, and the take-home message from the RTAC at this point was a child in cardiac arrest equals a child with trauma until proven otherwise. We had a discussion on that. We did have a report on ketamine use in the region. The action for that is twofold. We will review with agencies the protocols for determination of use, alternatives, and monitoring. Dr. Janikis, as regional or as medical director for Clifton Park, is developing a CME, and we've invited him via Jose to provide that as a regional CME on ketamine use. And we're further going to repeat ketamine assessment every 2 months and give that at the QI meetings as scheduled. Dr. Daly, anything else?
I think just a couple of things. You know, I'm excited to have John work on that ketamine CME, and that's going to be a great addition for the region. He doesn't even know that bus has hit him yet, but we'll make sure to warn him. We do have some background information to give him, which ought to help out a little bit. And I'm sure I'm going to volunteer Mike Broder as well, who I see on here. So I'm not really hitting him with a bus if he's on the call, but Mike is a resource for John as well. I think it's really important, given what we've seen with spit hoods in Rochester and ketamine in Aurora, Colorado, for us to make sure that we're staying ahead of these things, looking carefully at cases. Spit hoods, I think, are incredibly important to protect our providers. You know, I don't think there's anybody that's on this call right now that believes the spit hood was the source of the problem in Rochester. But it's something that became the proximate event to a death. The ketamine in Aurora, I'm not sure that anybody has seen the records closely enough to see exactly what happened there. But the closer that we can monitor the use of ketamine by our pre-hospital providers, the more likely we are to not lose this incredibly important and very efficacious medication, which we see being used both for sedation and for pain management in the field. It's being used in a significant proportion of the medication facilitated and rapid sequence intubations, both in the field and in the emergency department. And we just need to make sure that that we're watching it as closely as possible from a quality perspective, so that it doesn't become a political football that we have to deal with. So we're just getting ahead of a potential problem. So I'm excited about the efforts we're making at this point.
Okay. Tim, do you have anything for the Hawk?
Not a lot. Hawk met mid-September, and not surprisingly, the big discussion was on regional COVID ops and the impact on local hospitals. Just about everybody that participated on the call just reported routine and ongoing ops for, you know, all the local facilities. That was about it.
Okay. I'm going to jump back to the REMSCO because Steve was a little late, but he wants to say something.
Thank you very much, Rob. Just wanted to give a couple points on what's happening at the REMSCO. First, Rob mentioned the budget and the difficulties that may come. We do have an operating budget for next year, but that operating budget is based on the assumption that we are going to use some of our accumulated savings in order to pay for our expenses next year. I thought it would be important just for everyone on the Remac to know that we are anticipating as much as a 20% reduction in state funding. It's not certain, it's not even documented, but their state is starting to pay bills and reduce the amount they pay to 80%. Fortunately, our region has saved money over the years, and we can tolerate this for a year or two, or maybe even a year or three. But it will mean that we'll be very careful in the choices we make and where we invest our funds. So no real operational change that you would see in 2021, but certainly a lot of scrutiny about how we spend our money. Coincidentally, did want to let the CMAC know that our program agency is beginning talks with the Mountain Lakes Program Agency and potentially the ARMS Program Agency about developing a longer-term collaborative relationship that might lead to a merger of the program agencies. We're not talking about a merger of the REMSCOs, and we're not talking about anything that would impact the Remacs, but we are talking about bringing the staff organizations together. It's just in the exploratory phase. There's no commitment that's been made by any of the regions other than we thought it makes sense to sit down and talk, and the REMSCO approved us entering into those discussions, and a subcommittee from our region has been appointed. The third thing I would like to share has to do with COVID-19. A lot of things that have been done by Tim and his team to help us get through COVID in the fall, in the spring and summer remain. For example, the decontamination stations that have been set up. We have a keen eye on what's happening with COVID going forward and recognizing that we could see a resurgence. And we wanted to ask the members of the CMAC, especially the Remac, the hospital-based physicians, to keep in mind that the REMSCO and the regional program agency are here to support the EMS agencies and the emergency rooms as we go forward. If there are things we need to do, for example, Tim worked very hard in getting the filters for aerosol earlier in the year. We'd like you to keep in mind letting Tim know and letting the REMSCO know what you need. And fourth, tomorrow night, there is going to be a CME at 6 p.m. You've probably all seen the email from Tim. It's an online CME with Dr. Drew Anderson about preventing EMS suicide. Drew has done some real national groundbreaking work, and he's local from our region. If you are a medical director of an agency, I would ask that you forward that out to your agency. It's 1 hour online. The idea of this CME is to understand what's behind provider suicidality, to understand that it's okay to ask somebody that you think might be in pain how they're doing, and to help guide them in the right direction. I don't have to speak about what suicide has meant to us in this region. So if you're a medical director, we would ask you to check in with your team and make sure that it's not just a CME for the leaders, it's a CME for the rank and file. So thank you very much, Rob, for giving me a moment.
Yep, no problem. So agency updates. BLS albuterol, Ravenna Rescue Squad, CPAP approved by Remac last month. No ALS upgrade, BLS first responder, or EPCRs. Public access to fibrillation. There's the New York State Senate print shop, which is an update. GE Schenectady is original, and Waterford Fire Department's updates. New business, make sure everybody gets their flu shots or the spray up the nose. If you're over 65, get the high dose flu shots. Any more discussion on COVID communications and planning for the uptick that we're expecting in the next month or two?
Rob, I think the only thing that we should bring up here and likely ask Don to bring up at the CMAC will be why EMS personnel have been left off the Department of Health's mandates for influenza vaccinations, because it's been a notable omission in the past, and I think is potentially leaving EMS providers in harm's way, not to mention it being problematic for our patients. I'm not sure if we want to step out and say something about that from our pulpit, or we want to leave that to Don in December.
I can certainly bring it up at the CMAC.
You could bring it up as our suggestion from our region.
Absolutely.
Hi,
Just so you
Dr.
know,
Dale.
I was going to say, just so you know, the collegiate EMS organizations that we work with have now been put in a position where they have mandated flu shots.
Dr. Daly, I think it would be really appropriate for, I'm not a voting member of the Remac, so I can't make a motion, but I think it'd be very appropriate if the Remac were to send an advisory out to all agencies strongly urging that they encourage all of their providers to get flu shots, pending whatever happens at the state level.
I welcome motion as well.
I will make such motion.
I will second it.
Okay, all in favor?
Aye.
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 Any against? Okay. Any further discussion? Any topics?
Yes. This is Deb. Last month, I brought forward a request from East Glenville Fire for them to add the rescue vac to their truck, and it was tabled while additional information was gathered, because evidently there had been previous discussion on this. I have followed up with Dr. Daly. He was not able to find any additional information as of the time we spoke. So I first asked Dr. Daly, is there anything else? And then second, can I advise East Glenville to add this with appropriate information? Now, I have asked them to send information from their medical director, but I have not received that as yet. I do want to add that to here.
I think, quite frankly, without their medical director's endorsement, it shouldn't be on our agenda as a place to start. But I guess my secondary thought to this is that this is out there and is being marketed to the public. If they're going to choose to train to it and then put it on their truck, I don't really have a problem with it, but it is very much not the standard of care. Heart Association promulgated obstructed airway management would be the standard of care. So I think that's something that the fire district has got to make a decision as to whether or not they want to take on, and how they're going to maintain training for something that is such an incredibly rare event. I have no idea. So all of those things give me pause on this, but without their medical director pushing this concept forward, I can't think of any reason for us to entertain it.
I'm going to plead ignorance on this. The rescue vac I know of is a handheld suction device. It's been around for like 20 years. Are we talking about something else?
It's not the big gun appearance. It is a small handheld, hand-powered rescue device. So far, it has been approved in down on Long Island for use, and they've received and requested. We haven't found any place else in the state that has approved it, however. And my reason for bringing it up on this agenda without having their medical director's paperwork is simply to make sure that it remains transparent and in the public forum, as opposed to, the discussions that I've been having with others.
Okay, so I think we'll wait until their medical director weighs in if it's something they want to do.
Okay, that's fine. Thank you.
Any other discussion topics? Anyone want to bring something for us to bring to the December meeting?
Rob, it's Kathleen Crisafulli. I just want to go back to the mandated flu shot. I think it should be left as strongly recommended, but at best it's like 40% effective. So mandating, unlike measles, which is, 99 or very, very effective vaccine, this is not 100%, not nearly 100%. I think it should be left at the discretion of the provider. Only it's not 100% effective, at best it's 40. So to mandate something that isn't 100% protective, I don't think we should do it.
Any other discussion on that? My personal feelings are if it's 40%, that's 40% less infections you had. And if you don't mandate it and you get even less than that, you're talking even more potential infections. I think something that's as low risk, going for that 40% is probably better than not. But I'll leave that up to anyone else to discuss at this point. So
well, that's 60% of people that are being forced to do it that for whatever reason may not want to do it, which has been forced to have a vaccine that's not effective. 60% of them will have been forced to have a shot that doesn't protect them. It's about 40% effective.
But you never know who that 40% is.
That's right.
So I would leave. Does anyone else have any further discussion on this?
As opposed to mandated, we should say strongly suggested.
That's my point, that I think it should be strongly encouraged, but not mandated. It's not 100% effective. It's not nearly, not even 50% effective.
So you would have to make a motion to rescind the previous one and reword it to this. And I think for that, we'd have to go to a video vote. Cameron, are you weighing in or you're just off mute?
What? Was that directed to me?
No, Kevin was making some noise, but I guess he was involved. So do we have a motion to rescind what we just voted on and reword it? Because we'd have to vote to rescind that and then we'd have to vote on the new wording.
I'll motion that.
Is there a second?
I'd second it that we amend it to state that we strongly suggest that all encourage that all receive it.
Hi, Rob, this is Steve Kroll for a point of clarification. I thought that the motion Dr. Daly made was that agency medical director, that we strongly recommend that agency medical directors strongly encourage people to get flu shots. I did not hear the word mandate in there. Did I miss something?
No, I'm taking the minutes and that's exactly what was said.
Okay.
It was strongly suggested.
Then we have nothing else we need to do.
Okay, thanks for clarifying that. I thought we were voting on mandating it. I agree with what strongly recommend. Thanks.
Okay. Any further discussion? Okay, we will see you all in December.
Thanks, guys.
Good luck, everybody.